Welcome to As a Woman, Fertility, Hormones, and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and today we are talking all about your fertility, and I am answering your questions. These are my favorite episodes where you call in, leave the questions that are bothering you, and I get to answer them. One, because it's so interesting to me to see what questions are out there. Two, I know from experience that sometimes you don't even know what questions to ask. You want to learn more about your body, or you're going through infertility, yet it just seems like such a big, scary topic that it's hard to even dive in. Hearing other people ask their questions can really give you insight into how you feel about things, how your own body works, or things you may need to be considering for your own health. So I would love it if you would call and leave your own voicemail at 657-229-3672. Again, that is 657-229-3672. I'm going to be answering some of your top questions today, but before I do, a few housekeeping items. I have so many things that we've been working on behind the scenes as my platform has been growing and as we've been preparing for the Balancing Act book launch coming in the future. So if you are new here, welcome. I'm a board-certified fertility doctor, and I talk about fertility, hormones, health so that you can understand your body the best and make life plans and goals that fit with your life. And I believe the base for all of this is education. No matter your age, no matter your goals, you deserve and you need to know how your body works. So that is what we do here. You can ask questions online on Instagram at nataliecrawfordmd every single Monday. And some of those questions will be answered on Instagram. Some of them will be answered here on the podcast. On our regular episodes, at the end of each episode, we have a For Fertility's Sake Q&A segment where we take some of your questions and ask them. We also answer questions in the newsletter, and the newsletter is really exciting, has a lot of great content coming out. We have a new TTC Starter Kit freebie, which even if you're deep into infertility, has a lot of great lifestyle info, or if you're years remote from wanting to try, still helpful. You can get that by signing up for the newsletter at nataliecrawfordmd.com/newsletter. Also includes some of my favorite recipes and updates and discount codes, and some new exciting things for our newsletter community coming soon. But today is all about your voicemail questions. So again, 657-229-3672 if you have your own question. Today's episode is just potpourri of the random things you've asked. Sometimes we group them in category, but today is just general fertility Q&A. Let's dive in.
Hi, this is Chelsea. I'm a new listener to your podcast, and I have a question about my husband and I have been trying to conceive. We had a miscarriage back in March of 2024, and then I had acute appendicitis with laparoscopic appendectomy in April of 2024. Since then, we have not been able to conceive. It's been about 3 cycles. I have normal cycles. I got pregnant with my first child immediately after stopping birth control within 1 cycle, and I kind of expected it to happen again, which is when we miscarried. So my question is, with the surgery that I had where the appendectomy occurred and some mass was removed from my peritoneum on the left side, should I be concerned of any structural damage that could have happened with the miscarriage and then immediately following an appendectomy? Concern for inflammation. Thank you.
Hi, Chelsea. Welcome to the As a Woman podcast. I'm so honored to have you as a new listener. This is so frustrating and such a mind game. When you got pregnant with your first so easily, ready for the second, you get pregnant and you miscarry. And now you had to go through this surgery. Oh my gosh. And you're at the place where you're still trying and it hasn't happened. And it does lead to a lot of questions. This is a circumstance where, pending your age and how many kids you want, I would certainly seek a fertility evaluation sooner. So what I'm concerned about here is exactly what you're concerned about, and some of it might depend on the circumstances surrounding your appendectomy. So when you have a acute appendicitis, what is happening is that the appendix typically is on the right side and it causes a lot of inflammation. And this inflammation, if untreated, and the treatment is typically sometimes antibiotics and then surgery, and then removal, so laparoscopic appendectomy. But the appendix can burst and you can get a peritonitis and infection everywhere. And I have seen patients in both scenarios, a ruptured appendix and also just from acute appendicitis, have tubal disease, so subsequent scarring, and likely this is from that inflammation associated with that appendectomy, and that inflamed appendix caused tubal disease as well. So this is a circumstance where I would certainly consider asking your OB if they could order you an HSG, a hysterosalpingogram, or going and seeing a fertility doctor. And of course, how many kids you want and how old you are will play into this picture. But this is one of those circumstances where you now have a new risk factor that you didn't have, and now it is taking you longer to get pregnant. So ultimately, remember, even at our youngest, it can take us 4 to 6 months to get pregnant. But as more time goes on, the likelihood that something's going on is higher. So I would recommend you get it checked out. Wishing you the best, and welcome to the podcast.
Hi, Dr. Crawford. Thank you so much for your podcast. You make me feel so empowered. I'm 28 years old with an AMH of 0.3. I have infertility and I've had 2 miscarriages this year. I also have a luteal phase of about 8 days. My first question is, does my AMH alone explain those other symptoms? And then my second question is, what is my likelihood of success with IVF with that low AMH? And how many cycles should I expect to try to have a child? Thank you.
Hello, and oh my gosh, there's so much going on here. This is hard to give an individualized prediction, but I do think this is one of those circumstances where I would not rule anything out. And here's what I'm going to say. Number one, if you are hearing that you don't qualify for IVF at a certain clinic, please go get another opinion. Certain clinics will have AMH cutoffs in very young patients like yourself, and the reason why is to preserve their per cycle fertility success rate with IVF because of how SART guidelines are. There is a lot of nuance. I'm not the hugest fan because you are the perfect example of a patient who's going to need multiple cycles. You already are aware of this, but the success rate is about per egg retrieval is their most promoted success rate. So if I know that it's a low likelihood of success, I am incentivizing clinics to turn you away. When what we know is that you're young and your egg quality should be good, and ultimately you don't need as many eggs as somebody older. In your circumstance, I have had similar patients in your age range with an AMH like this. It can be really overwhelming, and I try to view this as running a race and you don't have to get to the finish line yet. Think about it that each cycle you're going to learn from yourself. Now, I would start out preparing for 2 cycles. Might you need more than that? Absolutely, especially if you want more than one child. Most people in your circumstance that I have treated have done 2 and more. We'll say between 2 to 4 cycles, pending their family goals. The truth is you have gotten pregnant even if you've lost the pregnancy. You have some cycle inconsistencies, which may or may not contribute, and you have a low AMH. Do we know why the AMH is low? Probably not, but that's just always a question I'm going to ask. When you think about the average number of eggs you're going to get with an AMH of 0.5 or less, we're typically looking in a category where we're going to get 6 or fewer eggs. The lower it is, the fewer the number of eggs. How many eggs do you need? Well, a single egg has overall, we usually say a 5 to 8% chance of turning into a baby. But of course, if you're younger, that's higher. One egg has about a 75 to 80% chance of being fertilized, a 50% chance of growing out to a blastocyst. And in your age range, we would say a 70% chance of normal. A normal blastocyst has a 65% chance of success. So ultimately, one egg can absolutely make it all the way through the process. All of those numbers are the most probable outcome. So I would not ever prohibit somebody in your shoes from giving it a chance, but I would go into this saying, without a doubt, I'm going to do 2 cycles. That's my mindset. And then I'm going to reevaluate my goals, how easy, how hard it's been. most people probably have had some success, meaning gotten some normal embryos, and might want to consider another cycle because this is your chance to grow your whole family. The decisions you make now will make a huge difference. To answer the other part of your questions, having diminished ovarian reserve or low AMH has been associated with having cycle abnormalities. Now, we do know that it's associated with a shorter cycle length, that's without a doubt, but most of the time we attribute this to follicular phase change because if you have fewer eggs, you're going to send a stronger signal of FSH from the brain. This is going to recruit an egg to grow faster, therefore you will ovulate sooner. That said, the corpus luteum is that follicle. So if you grew a follicle really fast, it might not be its most stable. You might have an abnormal luteal phase as well. And certainly 8 days is short on a luteal phase end. And some studies have shown a shortening of the luteal phase, some have not. I think this is in the literature where we can say for certain we see menstrual cycle changes, we see hormone abnormalities, and can this itself make it harder to get pregnant even if the low AMH particularly does not? Yes. We also see that the incidence of miscarriage might be higher based on the etiology of what got you into this low AMH. If you now have Hashimoto's or autoimmune disease, and that's what causing your low AMH, you have a higher chance of miscarriage as well. So it's not that the AMH is causing it directly, but there might be a connecting factor in all of these that I always think is important to explore. At your age range, this would mean genetics and autoimmune testing, just due to the low AMH. Ultimately, I would say, hey, you're young, let's give this a go. Get started on IVF with the right mentality in your mind. Know that you're doing everything you can. And that's all you can do. Take good care of yourself, sign up for the newsletter and get that TTC Starter Kit so you can make the lifestyle changes, and just dive in with a confidence that you're doing what you can at this point in time. And I'm wishing you all the best. Please give us an update.
Hi, Dr. Crawford. First, I love the podcast and listen every week while I am working from home. My question is, after having a DNC from a miscarriage, what is kind of a time period that you would be concerned if your patient has not yet gotten her period back? I had a miscarriage at 8 weeks and 5 days and had a DNC 8 weeks ago, and I still have not gotten my period back. My doctor kind of went over possibilities of Asherman's, but really wasn't super concerned. So I was curious, what are some things to look out for, as well as what are some preventative or proactive things I can do to discuss with my doctor to get my period back on track? Thanks so much. Love the podcast. Looking forward to hearing from you.
All right. This is always one of those that is just insult to injury in my mind. So after a DNC, now your body has to drop that HCG that it was making. And the further along you are in the pregnancy, the longer it will take for those HCG levels to drop. It won't be until that HCG is getting lower that your body will start to recruit an egg or send out any FSH and get you to ovulate. And then, of course, you have to ovulate before you'll have a period. So you'll have to grow that egg, ovulate, have a 2-week wait, not be pregnant, and then get that period. So here are the questions and thoughts that I have in this circumstance. We are dealing with likely one of two scenarios. Number one, you have not ovulated yet, so that's part of the problem. Or number two, you have ovulated, but you're not bleeding. So for number one, not ovulating yet, it could be that you just had a slow drop of your HCG. It took a while. The time period of which I usually tell people to have concern is if you are getting to this time. I say most people should have had their period by 6 to 8 weeks. If you get to the 10-week mark and you haven't, I'm wanting to do a further evaluation. This can either start with blood work or a regular ultrasound, or a saline sonogram is ultimately going to help you answer the second part of this question. But if you come in and we see an egg, I see a thick lining, I see that you're ovulating right now, that could be very, very normal. If you've had any symptoms of ovulation greater than 2 weeks ago, now I'm more concerned. So if you had some pain, sore breasts, anything in that realm, but you never saw a period happening, then I'm more concerned about Asherman's. For Asherman's, this is where you have residual scar tissue from the DNC. This is not common unless there was some complication or in an emergent scenario. So circumstances where Asherman's is more common is if the pregnancy was inside for a long time, if you potentially had hemorrhaging, infection, postpartum, or a further along second trimester or more loss, retained placenta, and then of course when you have uterine septum, uterine fibroids. Those are higher risk to have scar tissue inside the uterus. Asherman's is scar tissue inside the uterus. It's a complete obliteration of the regenerative endometrium. And this means that you're not growing a lining even though you're ovulating. Now, there's also versions of this. We act like it's complete, but I've had partial, and you can have trapped blood in a lot of different circumstances. The best way to try to diagnose this is also with ultrasound, but sometimes you need a saline sonogram to know for sure. The middle ground option here is that you have a small piece of retained placenta, and potentially this made HCG a lot longer. Therefore, you had a much longer decline until those levels were low enough to start to ovulate again. However, a retained piece of placenta can cause abnormal bleeding. And so I would anticipate you would have had some abnormal bleeding, even if it wasn't a full period, or you would still have a positive pregnancy test, but that retained placenta can turn into scar tissue and even Asherman's. This is a circumstance where I would start with taking a pregnancy test. It should be negative. If it's positive, could it be a new pregnancy? You would want to call your doctor right away. If it's positive, it's either a new pregnancy or there's something left behind. So then you're getting on the circumstance to go to a hysteroscopy, which is a surgery where we put a camera in the uterus and look and see what's going on. If you are negative, not a positive pregnancy, then I would recommend bringing you in for an ultrasound and blood work to try to see, are you ovulating? Is there a thick lining? Maybe this was just delayed. And I would often say, okay, based on this ultrasound, you're ovulating now. I should get a period in 2 weeks. If you don't, you should call me. Similarly, if you've got a nice, beautiful follicle and a very thin lining, then suspicion's going up, and the decision might be to do a saline or go on to hysteroscopy sooner. So you're right around that time where I would get a further evaluation. Sometimes scar tissue within the uterus is no big deal, easy to fix. Sometimes it's a really big deal. And I've had a few patients in my career, even though I am a fighter for Asherman's, I try to operate, do everything I can to prevent it from coming back, go right into cycle. I have a very specific approach, but sometimes it is what it is and you can't go and fix it. So the sooner you can get something diagnosed, the better. Last thing, if your periods were irregular before, this might just be a reversion to baseline and have nothing to do with the loss. I'm presuming they're not, or you would have told me. But another thing to think about is that it could just be irregularity, either new onset or from before, things like thyroid disease, prolactin abnormalities, etc. At this point, though, I think you should get a further evaluation if your periods are not back, and fingers crossed, it was just delayed return to ovulation. These questions are fantastic. I am loving it. So just a quick reminder that you can call and ask your own question by calling the As a Woman voicemail, 657-229-3672. Again, 657-229-3672.
Hi, Natalie. My name is Candace. I just want to say thank you for all you do for us women going through fertility problems or just trying to get more information. I love listening to all of your podcasts. My husband and I did embryo banking a couple years ago, and we ended up with 5 embryos. Our best embryo right now is a girl, a day 5 girl, but we are wanting a boy. But I was curious if our best boy was a day 6 hatched embryo, if that would really ruin our chances of a successful transfer, on how it really differentiates between a day 5 unhatched versus a day 5 or day 6 hatching or hatched embryo. Thanks. Appreciate it.
I get this question a lot about embryos, and I have a couple tidbits and then general advice. Congrats so much on having 5 normal embryos in the bank. That's an amazing accomplishment and sets you up for such success. 2, if you know you have a strong desire to have a child of one sex, I always recommend transferring that embryo first. Now, sometimes this is a greater discussion of how many embryos you have in your full family picture. For example, if you have 1 male and 4 female embryos and you know you want to experience having a boy, then I would say this is a normal male euploid embryo. We're going to transfer it because if it works, that's the only way for me to guarantee you're going to have a boy. And then I have 4 tries for you to have a girl added to your family. But if you want both and I transfer a female because it's a better grade under the microscope, somebody scored it higher in the beauty competition, and you have a girl, yay, it's amazing. And then you come in for that second baby and you have a boy and it doesn't work. Now what? Now are we doing IVF at a later, older age where I would know that male embryo isn't going to work now? Since it sounds like we have a sex preference and I didn't hear the full picture of the other embryos, that's what I would transfer first. And that is going to be the best way to build your family. The reality is a lot of the data about day 5 and day 6 embryos and their stage of development and hatching and not all came from before PGT data. So before we hatched embryos with the biopsy and before we sent off results knowing if they were euploid or not, we knew that day 5 embryos had a higher chance of being euploid than day 6, and if they scored higher in the beauty contest, they had a higher chance of being euploid. Therefore, they had a higher success rate over a non-euploid embryo. But now that we know day 5 and 6 embryos are both euploid, I don't hesitate to transfer either, especially if I have a couple who does have a sex preference. Now, if you tell your lab to pick their preference, here's what's going to go down. So fast forward if you don't want to know and you want to be surprised. They're going to look at your day 5 embryos. They're going to see which ones are euploid. If you have any euploid, then they're going to go with what's graded the highest of those. So letter, number, expansion is the letter. Most are going to be 4, 5. Letters are like school, A, B, C. A is awesome, B is average, C is below average. You have an inner cell mass, or what becomes your baby or the embryo, and you have an outer cell mass, what becomes the placenta. And you are going to evaluate those, and they would pick the best, the highest graded, and that would be what was transferred. And they'd go through your day 5s, and then your day 6 would be next tier. Of course, they'd only transfer the euploid. You would never transfer a day 5 mosaic that was prettier than a day 6 euploid. So that's what will happen if you tell the lab to pick best, because they want to pick by some criteria, not just random hand in the hat with the numbers. But the truth is, if you have a sex preference, then I would transfer that embryo first. And I would make sure it makes sense with the full picture, because if you said, well, we really want a boy and a girl, but we want a boy first, but you have 1 girl and 4 boy embryos, maybe that doesn't make sense. So that's a good discussion to have. It's really important to note that some clinics don't let you pick your embryo and they won't allow you to select for sex. I think that's bogus, because if I have the data, sex chromosomes are a part of genetic testing, you have a preference, somebody has to pick. Why should it not be you? Granted, my beliefs are not everybody's, so that's an important question to ask your clinic, especially if you do have a sex preference or you're doing IVF for what we call family balancing.
Hi, Dr. Crawford. My question is about that first period after the egg retrieval, specifically how the trigger shot that you use affects its timing. So I recently had an egg retrieval, and then 8 days after the procedure, my period came. In my head, I was picturing the retrieval as a form of like manipulated ovulation where the follicle still ruptures, becomes the corpus luteum. So I was expecting my usual 13-day luteal phase, and was surprised when it came much sooner than that. I asked my doctor about it, and she said that 8 days is pretty typical because I used Lupron as a trigger shot. And so I was wondering if you could explain this. How does the type of trigger shot that you use for an egg retrieval, how does that affect the amount of time before you get your next period? Thank you for everything you do to make information about fertility so accessible and understandable, and thank you for taking my question.
Fabulous question. Y'all are really starting to understand how our body's working, and great joy is coming my way because of this. So let's think about this, because there's a couple different things that are happening in IVF that are not like a natural cycle. So to your point, yeah, in a natural cycle, you're going to trigger surge. That's the peak of LH. This is going to cause that follicle to rupture. You will ovulate. Follicle will reform, and that will be a corpus luteum, and LH will stimulate this for about 14, we'll say 12 to 14 days. On and off, progesterone will rise and fall based on those LH pulses from the brain. And then when the corpus luteum dies, because it can only live about 12 to 14 days, progesterone will drop and you'll get a period. Let's remember, the stimulus for your body to get a period is the drop in progesterone. LH is what your body normally triggers. That's our natural surge. What's so interesting, if you've gone through IVF, you may notice I don't have an LH medication. I have FSH, Follistim, Gonal F, that's an isolated FSH compound. And I have a combination of FSH LH called Menopur. Now, Menopur is so interesting because it's actually purified from the urine of menopausal women, because when you go through menopause and you have no eggs, your brain starts to send out all of the FSH and LH that it has, trying to get the ovaries to kick back on and work. So we have this combo med, and we have FSH alone, and then we have other meds which can work by getting your brain to send out more FSH, like Clomid, Letrozole. But I don't have an LH alone. So when I want to trigger you, we actually use HCG as a trigger trigger shot. That's not what your body normally uses. But HCG is a typical trigger shot because it and LH are structurally similar and they can bind to the same receptors. So HCG does last in your body a long time. So sometimes we want to trigger you with Lupron, which is shorter acting, and this can help your hormone levels drop faster. And that's a mechanism to try to prevent ovarian hyperstimulation syndrome. Now, you can only use a Lupron trigger if you weren't on Lupron in the cycle. Lupron is what we call a GnRH agonist. Okay, remember, FSH and LH release is controlled by an area in the brain called the hypothalamus, and it releases something called gonadotropin releasing hormone. That's GnRH. LH and FSH are your gonadotropins. So when you use Lupron, how it works, it's an agonist. It upregulates. It actually tells your brain to send out all the FSH and LH you have there. But if you keep using it, it has no more. So then it's done. So when you use Lupron as a suppressant, you'll find that you started in the luteal phase when natural levels of FSH and LH are low or overlap with birth control pills. And you'll just have, there's no FSH or LH to release, so levels are low and then you're suppressed. But if you use Lupron as a flare or as a trigger, then the brain has FSH and LH, and then suddenly you get this surge of the pituitary gland dumping whatever it has, so you can have a lot of LH release. So Lupron can be used for a trigger in patients who are on an antagonist cycle, again, not a Lupron-based cycle, because then you have nothing left in your pituitary gland. And it can prevent OHSS or ovarian hyperstimulation because it's not going to stimulate those corpus luteum for very long. But also, in addition, in IVF, regardless of the trigger you use, your period does tend to come about 7 to 10 days after the egg retrieval. And the reason why is that we destroyed the corpus luteum. We poked them with a needle, took out their fluid, moved things around. We destroyed the cells that are normally going to be making progesterone. So even in the context of HCG, most people don't make it all the way to 2 weeks because we destroyed the corpus luteum and because it's the drop in progesterone. You had more corpus luteum, you're making more progesterone than you normally would. As they got destroyed, that's going to drop faster. Your body will see the drop and then you'll get a period. All right, friends. Well, these were the most amazing questions. I absolutely loved doing this just potpourri of fertility Q&A and think we'll do more soon. You guys have been calling and leaving questions, and I'm so thankful for you for doing so because it is allowing us to increase the number of these episodes that we have. So feel free to call and ask your own questions, or you can ask them on social media as well. So remember that you can ask questions Monday on Instagram at nataliecrawfordmd. On Instagram, we can go and answer those, and those questions will be answered right there on Instagram, in the newsletter every week, and at the end of some of our regular podcast episodes. You can sign up for the newsletter at nataliecrawfordmd.com/newsletter. If you want to call and leave a voicemail question, these are often, 1, easier to get answered because there's overall just fewer of them, and 2, you have a lot more space to tell me what's going on. Please call the As a Woman voicemail line, 657-229-3672. Again, that is 657-229-3672 for the As a Woman voicemail. Just want to say a huge thank you so much as we prepare for Balancing Act, my fertility book to be released. I'm just still so excited and thankful for this community that has put us in this position. Love all of the support you have. Sharing fertility-related facts, information, and the podcast episodes just helps us show that people are invested in learning more about their body, their health, their natural fertility, and helping you take charge of what you can control. Remember to follow along on Instagram at nataliecrawfordmd. You can also check out the YouTube channel, Natalie Crawford MD. We have totally different content over there, so short, bite-sized bits of your favorite fertility questions. And you can sign up for the newsletter at nataliecrawfordmd.com/newsletter. I appreciate you so much. Thank you, friends. Have a great day. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.